Welcome, everyone. Let's get started on chapter 26, CPT surgery section. This is one of the biggest chapters we're going to cover this semester, and honestly, it's one of the most practical ones. And to me, it makes the most sense. Um, if any of you end up working in the surgical center, a physician's office, or even a hospital outpatient coding department, what you learn here is going to come up every single day. Now, here's the thing about surgery. It's not just about knowing what code to use. It's about understanding how surgical procedures are classified, what's bundled in, and what's billed separately, and how the documentation you're reading tells you the whole story. We have 15 learning outcomes for this chapter, so we're going to move through them rather quickly. And there are quite a few slides, so get comfortable, or be willing to take a little break and then come back to this, because there's a lot of important stuff. And by the end of this presentation, this lecture, you'll have a solid understanding of how to approach a surgical procedure code. So let's get going. Alrighty, let's talk about what we're going to be able to do when we're done with this chapter. Learning outcomes 1 through 6 are on the slide, and I want you to notice something. These aren't just about memorizing codes. You want to look at the verbs, the distinguish, determine, interpret, identify, abstract, and finally apply. These are higher level thinking skills, and that's exactly what real coding requires. Learning outcome 26.1 to 26.3 are foundational. They set up how surgery is classified and how the global surgical package works. Those concepts underpin everything else in this chapter. Learning outcome 26.4 covers the unusual services, which is a big one for compliance and modifier use. Then there's 26.5 and 26.6, which takes us into the integumentary and musculoskeletal systems, two body systems with some very nuanced coding rules. We'll spend a good amount of time on each one of these. And then we're continuing on with learning outcomes 26.7 to 26.11. Now, notice how each of these outcomes is tied to a specific body system. The respiratory, cardiovascular, digestive, urinary, and genital systems each have their own section in the CPT surgery chapter, and each one has its own quirks and guidelines. I want you to think of these body system sections less like separate chapters and more like chapters within a chapter. The overall logic stays the same. You're always going to ask yourself, what procedure was performed and what site was it performed on? What was the approach? What's included versus what's get coded separately? So these questions will be your compass no matter what system you're coding. And this is, a lot like ICD-10 PCS. You're gonna look at the approach, the site, what's included. However, we're not using tables. We're using a different way of looking up code. So yet another language to speak basically the same distinction of what was completed. Before we get too deep into content, now let's get familiar with our key terms. Some of these you'll already recognize from the PCS. Others will be new to you, but you want to take a moment and scan through the list from allotransplantation to arthrodesis, closed treatment, complex closure, excision, laminectomy, etc. Now here's a tip. In coding, precision of language matters enormously. When a physician documents closed treatment versus open treatment, those two words change which code you're going to select. When they say simple closure versus intermediate or complex, that's a difference between three completely different code ranges. So as we work through this chapter, you want to pay close attention to terminology. The words in the physician notes are your raw material. Now, here are the remaining key terms: global period, harvesting, intermediate closure, surgical approach, and transplantation. I want to call out global period specifically because it connects directly to Learning Outcome 26.3, and it comes up constantly in real world practice. The global period is the window of time surrounding a surgical procedure during which certain services are considered bundled into surgical code, meaning they're not separately billable. If you don't understand the global period, you risk either undercoding or even worse, upcoding and creating a compliance risk. And you don't want to even touch that with a 10-foot pole. So we're going to look at this in greater detail shortly. So the first one, 26.1, learning outcome, types of surgical procedures. We're going to get a foundation for classifying why a procedure is being done and how it's being accessed. Now, think about it from a patient's perspective. When someone goes in for a procedure, there's always a reason. Either they're trying to prevent something, figure something out, or fix something. Those three purposes map directly to our three procedure types: prophylactic, diagnostic, and therapeutic. And then on top of that, there are different ways a surgeon can physically access the body. Those are our surgical approaches. So let's talk about the three purposes of surgical procedures. Now, a prophylactic procedure is preventative, or preventive, rather. The physician is trying to stop a problem before it starts. Think of prophylactic surgery to remove a precancerous lesion before it becomes malignant, or administering a series of injections to prevent an allergic reaction. Now, the key word here is prevent. A diagnostic procedure is all about gathering information. The physician needs more data, a biopsy, exploratory procedure, maybe a scope like a esophagogastroduodenoscopy or a colonoscopy, and that's to get closer to an accurate diagnosis. Notice the phrase in your notes. The reason for performing the test or procedure is to get closer to an accurate diagnosis. That language matters because it impacts how you code and how you link the diagnosis code. And then lastly, a therapeutic procedure is the fix-it category. The problem's been identified, now we're correcting it. Most surgical procedures you'll code are therapeutic. Keep these categories in mind and you'll read operative notes or as you read operative reports. Now, because the purpose can sometimes guide your code selection and definitely guide your medical necessity documentation. Now let's talk about approaches. How does a surgeon actually get to the area they need to treat? There are several options, and the approach is often embedded right in the code description in the CPT book. Starting with the least invasive, a non-invasive or external procedure code or procedure rather, doesn't enter the body at all. Think of it as radiation therapy applied to a skin surface or certain topical treatments. Minimally invasive procedures are increasing all the time as technology improves. The goal is to accomplish what you need with the least amount of trauma to the patient. The percutaneous approach means instruments are inserted through a puncture or a small incision. There's no big opening. Now, this is common for things like biopsies or certain injections. Percutaneous endoscopic approach adds a scope to it. So only are instruments going in through a small opening, but the surgeon is also visualizing the area through that same approach. Think of laparoscopic procedures. Continuing our surgical approaches, and these are important to commit to memory because they show up in CPT code descriptions constantly. The via natural or artificial opening approach uses a body's natural openings, the mouth, nose, urethra, rectum, etc., or an artificial one like a colostomy stoma to introduce instruments. There's no cutting into the skin. Via natural or artificial opening endoscopic approach adds visualization. So can think of a scope going through the natural or artificial opening so the surgeon can see and treat the area. And finally, the open approach procedure is the most invasive. That's when the surgeon actually cuts open the body, the skin, the membranes, the layers, to directly access what needs to be treated. These are your traditional surgical procedures, often performed under general anesthesia in an OR. When you're reading an operative report, you want to look for the language that tells you what the approach was. Words like laparoscopically, through a midline incision, transurethral, or via the nasal passage are all approach indicators. Next, we have 26.2, the surgical package. This is one of the most practically important concepts in this entire chapter. The surgical package, also called global surgical package, refers to all of the services that are considered bundled into a single surgical procedure code. The key idea here is that when you report a CPT surgical code, you're not just reporting the operation itself, you're reporting a package that includes related services before and after the surgery. Understanding what's in that package and what falls outside of it is absolutely critical for accurate and compliant coding. So, what's always included in the surgical package? Now, let's walk through that list together. First, E&M encounters provided after the decision to have surgery. Once a patient and physician have agreed to proceed with surgery, any pre-op E&M visits are bundled. You have local anesthesia, local infiltration, nerve blocks, topical, that's all included. General anesthesia is not included. That's coded separately by the anesthesiologist or the CRNA. The operation itself and anything normally considered part of the procedure. Now, this one requires clinical knowledge and what's normal to include. If the surgeon always closes the incision after a procedure, that closure is bundled in. Immediate postoperative care is the recovery room, PACU, um, which is what we often see as it's the acronym PACU. The immediate post-op monitoring. The follow-up during the global period is more than in this moment. It's in a 30-day, a 90-day, or whatever the procedure is, it's bundled into that code. And then we have supplies that's furnished in the physician's office, etc. Now, the bottom line is the surgical package is generous in what it includes, which is exactly why you cannot bill separately for these items. Now, service is not included. So it's important to understand what's not included because this is where we can legitimately bill for additional services. And we won't, we won't be um, accused, I would say accused, we won't be guilty for unbundling codes or upcoding. So diagnostic tests and procedures performed to work up the problem to determine what the problem is, those are separate. Post-operative therapies like physical therapy, after orthopedic surgery, wound care, etc. A more comprehensive version of the original procedure is, say, like a patient comes back and needs a bigger procedure than originally planned, that can be separately reportable. Staged or multi-part procedures is when a surgery is planned in multiple stages. Each stage is typically coded separately, often with a modifier 58. Management of post-op complications that require additional surgery is when you're looking at complications, the key word here is additional. If the complication requires a physician to return to the OR to do more, to fix the complication, that would be separate. Any unrelated surgical procedure performed during the post-op period of another surgery, that would get its own code with a modifier 79. And of course, there's supplies. This one's interesting because supplies are included in the office setting, but when performed in a facility, the facility bills for supplies separately. When you see any of these in the documentation, you want to flag them because they warrant their own codes. Global period is a span of time surrounding a surgery during which the surgical package applies. CMS defines these time frames and they fall into three categories: 0 day, 10-day, 90-day global periods. Understanding these time frames help you know which services are bundled and cannot be billed separately, and then what happens when a patient comes back during that window. Let's look at each one. The 0 day post-op period applies to endoscopies and some other minor procedures. Here's what it means. There's no preoperative period, nothing bundled before the procedure, and there's no post-op period or post-op days. The global period ends the same day. A visit on the day of the procedure is generally not separately payable. In practice, this means that for a colonoscopy, for example, if the patient calls the office that afternoon with a question and is seen, that visit is bundled in. But if they come back a week later and a problem that arose from the procedure, with a problem that arose from the procedure, rather, that visit could be separately billable depending on the circumstances, or it might be considered part of a routine follow-up. The 0 day period sounds simple, but don't let it trip you. Zero post-op days doesn't mean zero accountability. It means the clock resets after today. The 10-day post-op period applies to other minor procedures, things like removing a small cyst, a skin tag, laceration repairs. The global period covers the day of surgery plus 10 calendar days following. Like the 0 day period, there's no preoperative day bundled in, and the visit on the day of the procedure is generally not separately payable either. So if a patient has a minor procedure on Monday, the global period runs through that Wednesday of the following week. Any routine follow-up visits during that time are bundled into surgical code. If the patient comes in for something entirely unrelated, say a sore throat, or, stomach flu, anything like that, that's a different story and might be separately reportable with appropriate modifier. A 90-day post-op period is for major procedures, things like joint replacements, cardiac surgery, spinal fusions. The global period here is significant. 1 day before surgery, the day of surgery, and 90 days following. The preoperative day is the key. The day before surgery, the surgeon often sees the patient for a pre-op visit, and that visit is bundled in. It's not separately billed by the operating surgeon. The day of surgery is also not separately payable as an E&M. And then 90 days of follow-up post-op are included. That's about 3 months of routine post-op care, all bundled into that one surgical code. This is why surgeons are reimbursed at a higher rate for major procedures. They're expected to manage the patient's surgical recovery for that entire window without additional billing for routine follow-up. If something happens during those 90 days that requires a return to the OR, or if the patient develops an unrelated condition, those are separately reportable with appropriate modifiers. Learning Outcome 26.4, Unusual Services and Treatments. Now, as we know, not every surgery goes exactly as planned, and not every patient situation is straightforward. This section covers how to report services that fall outside the typical pattern, when multiple physicians are involved, and when the work was substantially harder than usual or special circumstances apply. When more than one physician is involved in a patient's surgical care, CPT gives us three modifiers to divide up the global package accurately. Modifier 54 is surgical care only. The operating surgeon performs only the operation. They don't do the pre-op or the post-op care. You would use modifier 54 to the surgical code on that physician's claim. Modifier 55 is post-op management only. It's a different physician takes over after surgery and manages the patient's recovery. That physician appends modifier 55 to the same CPT surgical code on their claim. Modifier 56, preoperative management only. Yet another physician manages the patient from the decision to have surgery up through, but not including the operation. They append modifier 56. Now, in practice, this comes up when a patient is referred to a specialist for surgery, but their primary care physician or another specialist handles the post-op follow-up care. Each provider bills their piece of the global package. When you add these up, 54, 55, 56, they should account for 100% of the global package value. These modifiers exist to ensure accurate payment distribution without double billing. For modifier 22, that's an increased procedural service. It's important to understand this because it's also really scrutinized by payers. Um, so let me give you a scenario. If a procedure is being performed, but for this particular patient, the work involved is substantially greater than what's typically required for that procedure. Maybe the anatomy is unusually complex. The patient's size creates technical challenges. There was excessive bleeding, scar tissue, etc. The physician put in significantly more time and effort than average. Now, when that happens, you want to use modifier 22 to the procedure code, and you must attach documentation that explains specifically why the additional work was required. That documentation should address the increased intensity, the time, technical difficulty, severity of patient's condition, or the physical and mental effort required. One important caveat from the slide, do not use modifier 22 to E&M codes. It's only for procedures. Next up is the integumentary system. This section covers the skin, the body's largest organ, and the procedures performed on it. The integumentary system is the bread and butter area of surgical coding because skin procedures are among the most common outpatient surgeries performed. We're going to cover biopsies, excisions, wound repairs, tissue transfers, skin grafts, and so on. Biopsies are about obtaining a tissue or cell sample for pathological analysis. There are several different techniques, and the technique matters for code selection. Fine needle aspiration. A thin needle draws out a fluid specimen, and it's common for thyroid nodules, breast lumps, or lymph nodes. When you read about a core needle biopsy, that uses a slightly larger hollow needle to extract a cylindrical core of tissue. And it takes out more material than a fine needle and allows for better pathological analysis of tissue. For the excisional and incisional biopsy, that removes an entire abnormal lesion. An incisional biopsy takes out just a portion of it. They're more invasive than needle biopsies. Endoscopic biopsy is during an endoscopic procedure, such as an EGD or a colonoscopy, and that specimen is grabbed using instruments passed through a scope. Now, why does the type of biopsy matter? What do you think? Well, eh, and I know you were thinking this, so awesome, good for you. It's because CPT has separate codes for each technique and sometimes for each anatomical site as well. You can't just code a biopsy. You need that level of specificity, right? It's all about specificity. Excision of lesions is one of those areas where coders really need to get comfortable with math. Yep, I know math. Oof. Let's walk through it. So each lesion excision is coded separately. If the surgeon removes 3 lesions, you have 3 codes. Second, the coded size is not just the size of the lesion itself, it's the size of the lesion plus the margins times 2. Why is it times 2? Well, I'm glad you asked. Because a surgeon cuts a margin on all sides. So both sides and then top. So you're adding the margin distance to both sides of the lesion. So what's the formula? The formula is the coded size equals the lesion size plus the margin times 2. So if a lesion is 1.5 centimeters, and you're always going to see it in centimeters or millimeters, not inches, and the surgeon takes out a 0.2 centimeter margin on each side, the coded size is 1.5 plus 0.2 times 2 equals 1.9 centimeters. That's going to push you into a different code than if you'd only counted the lesion itself. And here's something that's already included in the excision. Local anesthesia and a simple closure of the excision site. You do not separately code those that when they accompany a routine excision. If the closure becomes complex, however, that changes the picture. Wound repairs or closures are categorized as simple, intermediate, or complex. And when you have multiple wounds repaired at the same encounter, there are specific rules for how to add up and report them. If multiple wounds are repaired with the same level of complexity and on the same anatomical group of sites, add the links together and use one code for the total. But you may also have multiple codes to report, different complexity levels, different anatomical sites, etc. Now, in that case, you want to list codes from the most complex to the simplest, and then from the head to toe within that. All codes after the first one get a modifier 59, which is a distinct procedural service added to show that to the payer that these are genuinely separate, distinct repairs and not a billing error. Now, here's an example. If a patient has a 3 centimeter simple repair on the arm and a 2 centimeter simple repair um, on the arm, you're gonna so two separate simple repairs in two different locations on the arm. You're gonna add them up, a 5 centimeter simple repair, one code. But if one of them was complex and one was simple, you have two separate codes. Complex listed first, simple second with modifier 59. So let me say that again. So if a person comes into the ER, has a simple repair on the forearm and then a simple repair on the upper arm. They're both simple. You add up those numbers and you got one code. But if there's a simple repair on the forearm and then there's a complex repair on the upper arm, then that would be coded with the complex first, followed by the simple second. And on the second one, you would append modifier 59. Adjacent tissue transfer and rearrangement is when a surgeon moves healthy skin from one location to fill a defect nearby. Think of Z-plasty, the rotation flap, the advancement flap. These are all forms of tissue rearrangement. To code this correctly, you need two pieces of information from the documentation, the anatomical site and the total site of the defect. For the size, you add the primary defect, the wound being repaired, and the second defect, the area where the skin was taken from. Both are damaged, both count toward your goal. Then there's a rule for larger defects. For all defects over 30 square centimeters, regardless of anatomical site, you're going to use codes 14301 and 14302. These are the catch-all codes for large tissue transfers. When you're reading documentation, look for measurement of both the primary and secondary defect. If the physician only documents one size, that's a query situation. You're going to need both. Skin replacement surgery or grafts is another area where specific code selection logic applies. Skin grafts are used when there's tissue loss and that can't be repaired by just closing the edges. And think of burns, traumatic wounds, ulcers, post-excision defects. To select the right code, you need three things from the documentation: the size of the recipient area, the wound being covered, measured in square centimeters, the location of the recipient area, what body site is being grafted, and the type of graft, pinch, split thickness, full thickness, and so on. The codes include simple debridement or avulsion of the recipient site. So if the surgeon preps the wound bed and applies a graft, that prepped is bundled in. Full thickness grafts take both the epidermis and dermis. Split thickness grafts take just part of the dermis. The type of graph affects both the procedure codes and the donor site coding because someone has to code the harvesting of the donor site too. So for destruction, um, destruction is eliminating abnormal tissue without traditional excision. Now, these are common procedures in dermatology, so we see this a lot in derms. Cauterization uses chemical or electrical means to destroy tissue and seal off blood. Cryosurgery is liquid nitrogen, and the liquid nitrogen is a freezing. You've probably heard of it before. The extreme cold destroys the tissue cells. This is common for warts, actinic keratosis, precancerous lesions. Curettage uses a curette, which is a spoon-shaped instrument to scoop out the abnormal tissue. Electrosurgical methods use high-frequency electrical current to separate and destroy tissue without a scalpel. Laser surgery uses focused light energy, and yes, laser is an acronym. Light amplification by stimulated emission of radiation. For destruction coding, you'll need to know the method used, the type of lesion, and the number of lesions. CPT has separate codes based on these variables. All right, now we're going to head into the musculoskeletal system. Cast application and strapping is a concept that can really throw coders for a loop. Many procedure codes for treating injuries are already included, or treating injuries already include casting or strapping as part of the procedure. So you're not going to automatically add a cast application code on top of a fracture treatment code because it's already in there. But here's when you do separately code the cast. When the cast is not already included in any procedure for the injury, you're going to use codes from 2900 to 29799. Now, this can happen when a patient comes in for a cast change, when a different provider applies the cast, or when casting is the only service provided and there's no associated fracture treatment procedure. So you might see this in the emergency room. You might see a soft cast application to a limb, and that would be applied in an emergency room situation. Fracture treatments hinge on a very specific CPT definition of manipulation. CPT tells us that manipulation means the attempted reduction or restoration of a fracture or joint dislocation to its normal anatomic alignment by the application of manual applied forces. Keyword attempted. The surgeon attempts to realign the bone or joint by applying force with their hands. This is what distinguishes treatment with manipulation from treatment without manipulation. If the physician tries to reduce the fracture and can't, it's still coded as treatment with manipulation. The attempt counts. If they deliberately choose not to attempt reduction, say for a stable, non-displaced fracture, that's treatment without manipulation. This distinction appears right in the CPT code section. So understanding it is essential for selecting that correct code. Now, open versus closed treatment. Uh, these are terms that really do confuse students too, because people may assume that open means the fracture broke through the skin. That's not what these terms mean. Open treatment means the surgeon surgically opens the fracture site, cuts through the skin, the tissue to directly visualize and treat the fractured bone. It's defined by the surgical approach, not the type of fracture. Closed treatment means a fracture is treated without surgically opening the area. Now, the bone may or may not have broken through the skin, but closed treatment means the surgeon is not making an incision to access it. Percutaneous skeletal fixation is also an option, which is inserting pins or screws through small punctures. This is often guided by CT or by X-ray imaging, and It falls between open and closed. So an open fracture diagnosis with closed treatment is possible. A closed fracture diagnosis with open treatment also happens. So just pay attention to those little details. Penetrating trauma wounds include knife wounds, gunshot wounds, or injuries from any penetrating object. CPT's exploratory procedure for penetrating trauma includes all of these elements, exploring the wound surgically to find out how deep it goes, determining the extent, the complexity, identifying what structures were damaged, debriding the wound to remove foreign materials, and devitalize tissue. Note that qualification not severe enough to require a thoracotomy or laparotomy. Um, if the injury is so severe that the surgeon has to open the chest or abdomen formally, that becomes an entirely different, more extensive procedure. Penetrating wound exploration codes are selected based on the anatomical site. Spinal procedures involve some very, very specific terminology that you really need to understand. Um, and it is helpful to have, I found it when I've coded spinal procedures to have the anatomy of the spine in front of me, with the vertebrae, the different aspects of the vertebrae, because again, with any orthopedic procedure, specifically spinal, the surgeon will use that anatomy very uh, frequently. So you have to understand what's being done in order to code it correctly. So a laminotomy is a partial removal of the lamina, which is the bony arch of the vertebrae. This relieves pressure in the lumbar disc, and if there's herniation in that lumbar disc. Arthrodesis is a fusion of a joint in the spine. That means fusing vertebrae together to eliminate motion. Laminectomy. So it's a laminectomy, not a laminotomy. Laminectomy is a complete removal of the posterior vertebral arch. It's more extensive than a laminotomy. Percutaneous skeletal fixation is inserting pins or rods across a fracture site through small punctures, often with fluoro guidance. Lumbar puncture is a spinal tap. A needle is inserted between lumbar vertebrae to collect cerebral spinal fluid. This one is in the musculoskeletal section, but it also appears in the nervous system. Context, it really depends on what context you're using the code in. If it's for um, spinal tap or if it's for a lumbar puncture for surgery, for spinal surgery. Spinal coding also involves reporting the approach separately, the instrumentation separately, and the fusion levels separately. It's one of the more complex areas of surgical coding and typically requires significant experience to master. So that's why I say anything that you can do to help you understand the spinal procedures with the anatomy, use those tools. Definitely use those tools and those notes. Moving on to respiratory system. Sinus endoscopy is a diagnostic nasal spinal surgery. Um, and by definition, it includes inspection of all of these areas, the inferior nasal cavity, the middle and superior meatus, the turbinates, and the sphenoethmoid recess. Now, why does this matter? Because if a physician bills separately for inspecting each of these areas, that's unbundling and that's a compliance problem. And think orange or black and white stripes. You don't want to go there. All of these are included in the one diagnostic sinus endoscopy code. When there's additional services performed beyond that diagnostic scope, like removing a polyp, performing a biopsy, those can be coded additionally, but the baseline diagnostic inspection is always going to be one code. Pleural and lung biopsies are obtained by different approaches, and that approach determines the code. A percutaneous needle biopsy uses a hollow needle, often guided by CT imaging, inserted through the chest wall to sample lung or pleural tissue. No large incision is required. A thoracotomy-based biopsy involves surgically opening the chest. This is an open procedure, more invasive, but allows direct visualization and sampling. When a thoracotomy is performed, the biopsy is typically included in the thoracotomy code or reported with an additional code. There's also a thoracoscopy, which is a minimally invasive approach using a scope inserted through small chest incisions. Next, cardiovascular. Pacemakers is determined by two things, the insertion method and which chamber of the hearts are involved. Insertion methods is epicardial, which is placed on the surface of the heart, usually during open surgery, versus transvenous, which is where the leads are threaded through a vein into the heart chamber. Now, this is more common. It's a lot less invasive. Single chamber pacemakers pace either through the right atrium or the right ventricle. Dual chamber pacemakers pace both. There's also a biventricular device. Here's something important that's bundled into pacemaker codes. The insertion of the pulse generator, the transvenous placement of the electrodes, and moderate conscious sedation. So you don't separately code the sedation for a pacemaker insertion. It's already included in the code. Pacemaker coding gets complicated when you're dealing with revisions, replacements, or pocket revisions. Implantable cardioverter defibrillators or ICDs are similar to pacemakers, but serve a different, more urgent function. A pacemaker manages abnormal heart rhythm by pacing. An ICD does that too, but also monitors for life-threatening rhythms, ventricular tachycardia, or ventricular fib. And if it um, realizes that if it identifies that one or the other happens, it delivers a shock to reset the heart. CPT describes ICD systems as pacing cardioverter defibrillator systems that deliver a combination of anti-tachycardia, pacing, low-energy cardioversion, and defibrillating shocks. These are much more complex devices than standard pacemakers. Leadless pacemakers are newer technology that has its own CPT codes. These are tiny, self-containing devices, about an inch long, implanted directly into the right ventricle of the heart. Traditional pacemakers have a pulse generator, usually implanted under the skin in a chest pocket, connected to the heart via leads, wires threaded through veins. Leadless pacemakers eliminate both the pocket and the leads. The entire device lives out inside the heart. The procedure inserted via a transfemoral catheter through the femoral vein in the groin, up through the vascular system, and into the right ventricle. There's no chest incision and no pocket. Coronary artery bypass grafting, or CABG, is coded with careful attention to what type of graft material is used. Venous grafts use codes 33510 to 33516. All of these include the saphenous vein grafts. The saphenous vein is a long vein that runs down the inside of the leg, and it's commonly harvested for bypass grafting. Within the range, the codes differentiate by the number of grafts performed. Arterial grafts use codes 33533 through 33536. These use arteries rather than veins: internal mammary artery, gastroepiglotic artery, or epigastric artery. Note when harvesting the saphenous vein, it is included in the venous graft codes. Harvesting of the arterial conduit is included in the arterial graft codes. You do not code these separately. When a bypass graft uses both venous and arterial grafts, a combined arterial venous bypass, you need two codes. First, a code from 33517 to 33523, which is the combined arterial venous graft code. The number of venous grafts determine which specific code you pick up within the range. Second, you add the appropriate arterial graph code from 33533 to 33536. The harvesting of the arterial section is included in this code. So if a patient has a three-vessel bypass using two saphenous vein grafts and one internal mammary artery, you'd use a combined code for the venous component and an arterial code for the mammary. Composite grafts are special situations in bypass surgery. When two or more vein segments are needed, they have to be harvested from a limb other than the one undergoing the bypass. And you're going to use codes 35681 to 35683. These codes cover the harvesting and the anastomosis, the connection, the surgical connection of those multiple vein segments. The anatomical location of the harvest site matters here. It needs to be from a limb separate from the operative site. Think of this as a secondary procedure that supports the primary bypass. For the primary vascular procedure codes in the range 34001 to 37799, CPT guides specifically what's always included. Three things are bundled in, ensuring the inflow and outflow of the arteries and veins involved. So the surgeon's responsibility for making the repair work in both directions is part of the code. The operative arteriogram performed by the surgeon during the procedure, if the surgeon does their own imaging during the case to assess results, that's in. And, sympathetically for the aortic procedure. Understanding these inclusions prevents unbundling, reporting separately what's already part of the primary procedure code. All right, we're moving right along here. I know it's a lot. Bear with me. If you need to put me on pause, take a break, stretch your legs, come back, by all means do it because it's a lot to absorb. So I'm going to actually take a sip of my water. Okay. All right. Catheterization of the arteries uses a family-based coding system. This is what CPT calls vascular families, and the key reference is in CPT Appendix L. Believe me, catheterization of the arteries. Now, doing circulatory system is very complex, and only the most experienced of coders do the circulatory system because it is so complex. Um, Just as a review, a vascular family begins at the vessel that branches directly off the aorta, femoral artery or carotid artery. Each vessel that branches from that origin vessel is part of the same family. Here's why it matters. First order, second order, and third order catheterizations are coded, and they're coded differently depending on how many vessel branches you navigate to reach your target. If the catheter starts at the aorta and is advanced into a first order branch, one code. If it's advanced further into second order branches, it's a different code. This is a section where having your CPT code book open and your Appendix L bookmark is really important. Now, central venous access devices, or VADs, are used for long-term medication delivery, chemotherapy, TPN, or frequent blood draws. Coding them can be tricky because the CPT guidelines are specific about what qualifies as a central VAD. The definition is the tip of the VAD or catheter must come to rest in the subclavian vein, or the brachiocephalic, which is a nominate vein, the iliac vein, superior or inferior vena cava, or the right atrium. If the tip doesn't end up in one of those vessels, it doesn't qualify as a central venous access device for coding purposes. A VAD also distinguishes by whether it's centrally or peripherally inserted, whether it's tunneled or non-tunneled, and whether there's a port or a pump. You want to really look at that documentation because that's going to specify the insertion site, the tip location, which would be confirmed via imaging, and then the type of the device. All right, yay, we're done with that part. Whew. Cardiovascular and circulatory always makes me nervous. It's just there's so many little details that you got to get in the picture and discuss. So, moving along, digestive system. Endoscopy is all about a camera and using that visualization. That camera is at the end of the scope and it's used to look inside an organ and when needed to treat what's found there. So let's review the major GI endoscopic procedures. The EGD is an esophagogastroduodenoscopy, and that examines the esophagus, stomach, and the first portion of the small intestine. That's common for evaluating GERD, ulcers, dysphagia, and upper GI bleeding. An ERCP is an endoscopic retrograde cholangiopancreatography, which uses a side viewing scope to examine and treat bile ducts and the pancreatic duct. This is often used to remove gallstones from the common bile duct or to place stents. Sigmoidoscopy examines the sigmoid colon and the rectum. Colonoscopy goes all the way to the cecum, the full large intestine. For CPT coding, what matters is which scope was used, how far did it go, what was done during the procedure. A diagnostic colonoscopy is only one code. Now, a colonoscopy with polyp removal is a different add-on code. So you have to pay attention and you have to pay attention to how it was removed. Was it removed with a cold smear or a biopsy, let's say a forceps or hot snare? So you have to pay attention to how it was removed. Um, Nasogastric tube insertion is a procedure you'll encounter documentation on frequently, and this particularly happens in inpatient settings. An NG tube is inserted through the nose, down the esophagus, and into the stomach. The reasons are varied: gastric decompression, removing stomach contents before or after surgery, or to treat a bowel obstruction. For coding purposes, the documentation should indicate why the tube was placed. The indication matters for diagnosis coding, also affects which procedure code applies. Hernias are also common, and hernia repairs are one of the most frequently performed surgical procedures. CPT hernia repair codes are selected based on the type of hernia, and there are several. There's the inguinal, which is the inner groin, the outer groin, umbilicus, and there's also the hiatal hernia, which is between the esophagus and the stomach, and an incisional hernia. Beyond hernia type, the code selection also depends on the patient age, whether it's initial or recurrent, reducible, or incarcerated, strangulated, unilateral, bilateral, and then, of course, if mesh was used to help repair the code. Bariatric surgery or weight loss surgery is performed for patients with severe obesity and associated comorbidities. Um, there's different codes for each type of surgery. An adjustable gastric band or an AJB is 43770 to 43774. This is where a band is placed around the upper part of the stomach to create a small pouch. It's adjustable and the physician can tighten or loosen it. Then there's a Roux-en-Y, gastric bypass, and that's the most commonly performed bariatric procedures. The stomach is reduced and the small intestine is rerouted to bypass part of the digestive tract. The biliopancreatic diversion with duodenal switch is a more complex malabsorption procedure for patients with really high BMI. Then there's a vertical sleeve gastrectomy, and it's about 80% of the stomach is removed, which leaves a sleeve-shaped pouch. Now, the coding also includes a laparoscopic versus open. The approach matters for code selection across all of these. Let's move on to the urinary system, and that includes the kidneys down to the urethra, and there's a whole variety of complexity. Urinary catheterization includes or is inserting a catheter into the bladder and is documented in various ways. Foley catheter is an indwelling catheter with an inflatable balloon to hold it in place in the bladder, is standard for long-term drainage. Robinson catheter is a straight flexible catheter used for in and out catheterization. Carson catheter, specifically designed for male patients with prosthetic obstruction. Then there's the Code or Tiemann catheter, has a curved tip to navigate the curves of the male urethra. Now, each serves a specific clinical purpose. While CPT doesn't always code differently based on catheter type, the documentation details give you the confidence in the procedure being performed and inform the diagnosis code. Next, we have urodynamics, which is a study of how the bladder stores and releases urine. You codes 51725 to 51798. It's a comprehensive section of services that include all of the equipment, supplies, and technician fees used during this testing. Now, it's important to note, if the physician performed the procedure, you use the full code. If the physician only interpreted the results, i.e., read the report, signed off on findings, but didn't actually perform the study, you're going to add modifier 26, which is a professional component to the code. Cystourethropy is also called a cystoscopy. It's an endoscopic examination of the bladder and urethra. If the physician places a self-retaining indwelling stent, one that stays in place, that's separately reported. Percutaneous genitourinary procedures, things like nephrostograms, or uretograms are diagnostic imaging procedures performed through a puncture approach and using imaging guidance. A nephrostogram involves injecting contrast material through a nephrostomy tube to visualize the kidney and ureter. A ureterogram similarly visualizes the ureter. Moving along to the genital systems for male and female. The male genital system is anatomically adjacent to the urinary bladder and urethra, which is why a urologist, a specialist in urinary tract diseases, is often the physician performing procedures on both systems for male patients. Peyronie disease is a penile plaque. It's a condition where scar tissue forms inside the tunica albicunea, the thick membrane surrounding the erectile tissues. The scar tissue can cause painful, curved erections and make sexual intercourse difficult or impossible. Treatment options include injections directly into the plaque, steroids, interferon, or other agents, and the injection goes directly into the scar tissue site. Vulvectomy coding requires attention to very specific terms the physician uses. Now let's go through each. Simple vulvectomy removes skin and superficial subcutaneous tissues, and it's less extensive. Radical vulvectomy removes skin and deep subcutaneous tissues, which is more extensive. Partial vulvectomy removes less than 80% of the vulvar area. Complete vulvectomy involves more than 80% of the vulvar area. Maternity care in CPT is often reported as global obstetric package, one code that covers all antepartum visits, the delivery, postpartum care, but it can also be reported in components when care is split between providers. Antepartum is the prenatal period, includes the initial history and physical, subsequent visits, weight, blood pressure checks, fetal heart tones, routine urinalysis. CPT defines the expected visit schedule, monthly visits from conception through 28 weeks, biweekly every 2 weeks, from 28 to 36 weeks, and weekly from 36 to delivery. Delivery services are the second component of the obstetric package. When reported separately, delivery includes admission to the hospital, admission history and physical, management of uncomplicated labor, monitoring contractions, fetal heart rate. Delivery can be vaginal with or without episiotomy, without forceps or cesarean section. Postpartum care is a period immediately after delivery, and it begins at delivery and extends for approximately 6 weeks. Next is the nervous system. And nervous system includes skull-based surgery, which is very complex and is typically reported in components. You code the approach, the definitive procedure, and the repair reconstructives separately. This explicitly states in CPT guidelines for the procedure, so you really have to pay close attention to those guidelines in the CPT code book. The approach describes how the surgeon gets to the operative site. Is it craniofacial, orbitocranial, transcochlear, other approaches? The approach code reflects the access. The definitive procedure is what the surgeon did once there. Resection of a tumor, excision of a lesion, repair of an aneurysm, biopsy, etc. The repair reconstruction is coded when a secondary repair is required to close the wound or reconstruct a surgical site after the procedure. Pain management under the nervous system covers a variety of interventional approaches, and this includes electrical reprocessing, specifically transcutaneous electrical modulation pain processing, or TMPR, which is a technique that uses electrical impulses designed to interrupt pain signals. Each treatment session is reported with the Category 3 codes 0278T. Now, remember, Category 3s are temporary codes for emerging technology. Epidural and intrathecal medication administration involves delivering medication directly into the epidural space or intrathecal space, directly into the cerebral spinal fluid via the subarachnoid space in the spinal cord. This is used for chronic pain management, cancer pain, and spasticity. Intravenous therapy is when the pain condition is chronic, it requires long-term IV meds. A PICC line may be inserted. PICC lines are peripheral inserted vascular catheter or central catheters, excuse me, and they have their own insertion codes. Okay, next we have the optical and auditory systems. We have about 8 more slides to go. We're almost done. I know this is a really super long lecture. And if you're still with me, kudos to you. I'm so proud of you. Um, I know it's not easy sitting through a lecture, but all of this material is so important. And if you're here listening to me, this tells me that you really want to do good in this class and you're really dedicated to learning coding and CPT. So I want you to take your right hand and put it on your left shoulder and pat yourself on the back. Okay? Good job. Now, for the optical system, there are 3 key optical procedures. There's glaucoma surgery, vitrectomy, and a dacrocystohorostomy. That's a tongue twister, or DCR. I like DCR better. For the glaucoma surgery, glaucoma is a condition where excessive fluid raises pressure inside the eye and can damage the optic nerve. Surgical treatment involves making an incision in the trabecular tissue to create a drainage pathway for the excessive fluid. Vitrectomy is the removal of a vitreous gel from the center of the eye. It may be necessary if there's a retinal detachment, a vitreous hemorrhage, or any other condition which impacts the posterior segment of the eye. The DCR treats nasolacrimal duct obstruction. It creates a new drainage pathway directly from the lacrimal sac to the nose. The auditory system is organized by anatomic region. We have the outer ear, the middle ear, and the inner ear. Outer ear procedures are included on those pinna, which is the visible ear structure, and the external auditory canal and eardrum. Middle ear procedures include myringotomy, which is an incision into the eardrum, often for like a ear tube placement. The inner ear procedures include those for conditions like Meniere's disease and other cochlear implantations. Documentation should specify the atomical region, and the and which ear, and bilateral coding rules apply. Organ transplantation. In the CPT, there are three distinct steps, each of which can be coded separately and may be performed by different physicians. Step one is to harvest the donor organ. The surgeon retrieves the organ from the donor. This is coded separately with donor procedure codes. Step two, backbench work. After retrieval, the organ is prepared for transplantation. It's cleaned, it's preserved, repaired if needed. Backbench work codes report this preparation. Step three is transplantation, actual placement of the organ into the recipient. So it's important to know that allotransplantation means the tissue comes from another individual of the same species. So that's like human donor to human recipient. This is a standard organ transplant. Transplantation is a general term for the transfer of tissue from one site to another. Next, we have the operating microscope or microsurgery. And this is actually the second to the last slide. Almost there. The rules for reporting the microsurgery are code 6990, microsurgical techniques requiring use of operating microscope. In order to use this add-on, it's always reported in addition to the primary procedure. You would never use this as a standalone code. Second, you do not use modifier 51 multiple procedures if you use this code. Add-on codes are exempt from modifier 51. Thirdly, you want to check the primary procedure code description. Some CPT codes already include the use of the operated microscope in their description. So just make sure that if you add on that 69990, you want to ask, does the primary code description already include the microscope? If it doesn't, you can add it. If it does, do not add it, and do not add a modifier 51. All right, we've reached the end. Let's pull it together. The surgery section of CPT is very complex, very broad. It's organized around a consistent set of principles. When you approach any surgical code, you're always asking what procedure was performed, what's included in that code's description, what falls within the global package, and what gets coded separately. One key reminder, the surgery section covers way more than just operating room procedures. Simple procedures like removing a splinter, or treating a wart, draining an abscess. Those are all in the surgery section too. Don't let surgery intimidate you or cause you to overthink easy cases. The third step approach from your text is worth committing to memory. Identify the components of the operation, determine what's included in the code description, and determine what requires separate coding. So, great work. Thank you for sticking with me for 68 minutes. Make sure you review the key terms, you understand the global package concepts, and you know your modifier options. And as always, reach out if you have any questions. I'm here for you. You got this. Okay. So thank you and have a wonderful week.